Welcome back to the RT Clinic. Today's video, I am doing the basics of assisting with intubation. This is for everyone to watch. Ready? Let's go. All right, so we're back and we are looking at assisting with intubation. Now we know that if somebody's going to perform intubation, they have to have specific skills for that, and that's not for everyone, but anybody that's in a situation of respiratory arrest or where an endotracheal tube or airway assistance is needed, they could be pulled in. I'm talking about respiratory therapists, nurses, physicians, anyone that's in the room. You really need to know some key aspects, and that's what I'm going to go over today of assisting with intubation. So the first thing we're going to talk about is the person that is going to be intubating the patient. Now this is Fred. Say hi, Fred. How's everything going? This is Fred the head. So we're going to use him. I'm going to talk a little bit about how that assistant is going to help the person that's actually placing the airway, because you're really only as good as the person that's assisting you. And so in this case, the person intubating is going to be at the head of the bed, and that's the way it almost always is placed inside the healthcare setting or even outside the healthcare setting. Head of the bed gets you the best view of the patient, obviously their oral airway, and then down to their chest to look for chest rise. And so that person is going to be using, if we're talking about direct laryngoscopy or DL, we're talking about they're going to be using a laryngoscope. And so I'm not going to talk about these today. I'm going to do another video where I talk about these a little bit. But this is an important key. The assistant, so this is the key part, the assistant always places himself off to the right-hand side of the person intubating. So left-hand side, right-hand side, the person assisting will be right here where this bag valve mask is. And there's a couple key reasons why you need to be right there. So with the laryngoscope, sometimes the person that's going to intubate doesn't know how to set up certain aspects, although they should. And so having a laryngoscope blade and handle and making sure that they go together and that the light works is really important. So if you're preparing for intubation, not if you don't even have to be doing intubation, but preparing, setting up, one of the things you're definitely going to check is make sure the laryngoscope light works. We always put the blade in, we turn it on, make sure it works. You don't want to get down into this, looking in the oral pharynx and turn this blade on and the light doesn't work, because what you've done at that point is you've probably hyperventilated the patient a little bit, you got them fully sedated, and now you're scrambling to find that piece. So making sure the laryngoscope blade works is number one. Okay, so second thing, when you're assisting off to the right-hand side, you're probably going to be assisting with bag valve mask ventilation. And we've talked about this before. Bag valve masks, obviously, it's a self-inflating bag. If I squeeze it, it self-inflates, pulls whatever oxygen's running from here. In this case, I don't have anything running in, but you'll have at least 15 liters of oxygen running in here. This bag will be inflated. It delivers the breath, pulls the 100% oxygen from this bag back into here, so the next breath goes to the patient. So having this set up, having the mask on is really key, having the flow meter turned on, and having everything running off to the person intubating off to their right-hand side. So that's another piece to it. Another one is preparing the endotracheal tube. So there's, first one's laryngoscope, we have the bag valve mask, now we have preparing. So the standard endotracheal tube will look something about like this. This is a size 8, as you can see on here, 8.0. That tells you the inner diameter of the tube. Most adults, we're going to use 7, 7.5, 8, 8.5 for those sizes. The person intubating actually picks. And so if I'm in there with a physician, I'll say, what size tube would you like? If they're not for sure, I'll give them a 7.5 or an 8. But those are a couple of real keys when setting this up. So this comes out of a package. It's sterile. Okay, I'll take that off of it for now. This comes out, and we usually kind of leave it in the package. But one thing we definitely have to do, and it's a part of that job of assisting with intubation, is checking this cuff. So this is the cuff that actually seals inside the airway. And so this doesn't hold it in, but this has to inflate to occlude the airway so that when we deliver air in, that it will go directly to the lungs and not come the path of least resistance, which is out the mouth. That would do really no good if we were sticking a tube and it didn't seal. So this seals inside the airway. This is endotracheal tube cuff. And so how do we test that? We take out a 10 cc syringe, you apply it to this little piece that hangs off right here. There's a little, this is kind of like a lure lock, if you will, and there's a spring inside of there. So this doesn't screw on. As you can see, it's just, there's no actual pieces of screw on there. So we just kind of push it on and do a little rotate, plastic on plastic, and it holds really tight. And then what I'm gonna do is I'm gonna instill 10 mLs of air, and I see that cuff inflate. This is called the pilot balloon. This gives you an idea how much pressure is in the cuff, but it's not perfect. But what I'm gonna look for is see this cuff inflate. Okay, I know that it holds air, and now I'm gonna deflate it back, pull it all out to make it, bring it back, pull it in as close to the tube as I can, so that when we do go to intubate, we can go in. I usually, and it's personal preference, but I leave the syringe attached, because after the tracheal tube is in, sometimes you're fiddling a little bit to try to get that attached. I usually leave it attached. So this entire piece will still be in the package. The top might be opened up. You've checked the cuff. You see it holds air. You don't have to put a bunch of air into it, because technically it's not going to blow up that large. It's going to seal in an airway. And so it's going to go from about like this inside the airway. This is a good representation. And it's just, you're not going to even have to put a full syringe in usually, and it's going to close it off. So just because the cuff doesn't look like it's real big and tight, that's okay. This isn't like a Foley catheter that you're going to fill up and has to stay in there. This just has to seal in the airway. So we're verifying that the cuff is intact. And you know, these actually these are kind of cheaply made. They can come from the manufacturer with a cut in it, or maybe somebody was fiddling with it, or it was stuck in a bag somewhere, even inside the package, and that was lacerated. You want to make sure this cuff holds air, has integrity before you go for the intubation. Just like with the laryngoscope handle, to making sure that works, you want to make sure this works first. So setting up the equipment is really important. The next thing you're going to use with the endotracheal tube is going to be your stylet. And this is a semi-rigid stylet. They usually come in a package where they're kind of packaged somewhat straight like this. This one's already been kind of bent a bit, but you're going to actually insert this thing inside the endotracheal tube. So this goes inside the endotracheal tube, as you can see here, and it's curled at the end. Now that curl does not tell you much of anything at all, because if I go all the way down to the curl, you notice what's sticking out the end here. That's not good. That is a semi-rigid stylet sticking out the end, or I like to think of it as like you're trying to gore something. We do not want to do that inside of their airways, as you can imagine. So when we insert this stylet in to prepare for everything that's going to be going on with intubation, usually you go about to this place right here. You see this hole here is called the Murphy's eye. And so you could get about to the Murphy's eye, which you can see it right there kind of sticking out. I usually pull it back to about cuff level or so. And then once you're at that piece, you see we still have quite a bit sticking out. You take this and you just bend this over like that. Now don't bend it and wrap it and whatnot, because you're going to have to withdraw this. But now you see at that point, it's no longer sticking out. And if you can't see, it's about mid-cuff level. So mid-cuff level is a good place to be for that. The next thing I like to do is to ask the person that's intubating, do they like their tube bent a certain way? So some people have preferences, most people don't really care. But I've worked with some maybe anesthesiologists before that like a specific bend. So this is one specific bend. I've heard this called a hockey stick before. So that is a straight 90-degree angle. If somebody doesn't have a preference and they don't tell you, I usually just put a slight bend on it, something about like this, and then let them actually manipulate that if they need to change it at all. This is usually enough to be able to intubate, and then if they need to bend it anymore before they insert it, that's key. Now, one of the areas we like to keep really clean during this is definitely from about this level right here down. And so if all this can be done with that inside of the package, it's really important, because think about this, especially if I didn't have no gloves and I was touching the end of this, or even if I had gloves on, because they can be dirty also, this is going to be below the cuff. This is going to be in the warm, dark, moist area, and definitely can grow bacteria. And you don't want to intubate somebody and have them end up with a ventilator-associated pneumonia or something in the future, because you contaminated this area. So I pay real close attention when I'm setting this up. It's about half the tube down to make sure that that's not being touched, stays inside the either side, inside the bag. So we open the bag up halfway or the packaging up halfway. Leave this bottom half in if you can. Even leave it in there until you are ready to give it directly to the person that's intubating. Now let's go over back to the mannequin so I can show you kind of how it's going to work when you're assisting. And the fourth piece of equipment that you need when you're assisting is you need to have some type of securing device. This is a Marpac securing adhesive tape. Sometimes you have a commercial device that will go on there, but those are the 4 different items that you'll have. Endotracheal tube attached with the syringe and the stylet. That's one. Bag valve mask here, laryngoscope blade and handle, and then your securing device. These are 4 pieces that you really need to have because the person that's going to intubate this patient is going to secure this endotracheal tube with their fingers, and then the person that's assisting will then go to number 4, which is helping to secure that. I'm not going to go through that today because I'm just talking about the basics of assisting with intubation. So let's put everything in order here. Bag valve mask, laryngoscope, we have endotracheal tube, and we have securing device. So I did say there were 4 things. There's actually 5 things. So the 5th one is having suction set up with a rigid tonsil tip. We can call this a Yankauer or whatever it be, making sure suction is functioning. These are the 5 different pieces from suction, bag valve mask, to laryngoscope blade and handle, endotracheal tube, and then we have our securing device. Those 5 things, and I'm going to do them in order, is what you're going to need if you're assisting. Now remember, the assistant's always off to the right-hand side. So if I'm going to go in and I'm the person intubating, I'm going to have the suction down at this point. I may be doing some bag valve mask ventilation. I may use the assistance of my assistant on the side to be able to help secure this until we're ready to go. Now, once we're ready to go and the patient's sedated, we're going to go in and I'm going to set this down. The person intubating, you would hand them this, or they can grab this. Sometimes they'll keep this themselves, the laryngoscope blade and handle. They will go to insert. Now this always goes in with the left hand. This is a real generic intubation lesson. It always goes in with the left hand, and you can see the viewing areas here. Endotracheal tube always comes from the patient's right side, which is why you're placed on the right side. So they're going to go in and they're going to look. And when they go in to look for intubation, they're going to be trying to visualize the vocal cords. There's 2 different things that the person intubating may ask for. They may ask for suction, and they may ask for the endotracheal tube. So the person that's waiting here, gloved and ready to go, should be ready like this. Endotracheal tube, usually a package over the bottom half, and then the suction, because the person intubating is going to ask for one of those 2 items. So if I go in and I see a lot of mucus, or I see some occlusion, some things I don't want to push down to the lower airway, I may ask for suction. So a lot of times when I'm looking and I'm intubating the assistant, I may say I need some suction, and I'm looking for, and that's why I'll reach right here with my right hand, looking for this suction to be handed to me somewhat like this. Now this, if you handle it like this, it's not a big deal, whatever way, but the best way is to have it turned on, full suction, so that I'm looking and it gets handed to me like this, and I can go in and clean out some areas in here real quick. And usually when they're finished using this, they're going to ask, can you hand me the tube? And so when intubating and when you visualize the vocal cords, you're going to want to keep your eyes on the vocal cords. But the assistant on the side is there to be able to hand you things as you need them. So I'm going to go in and I'm going to find the vocal cords. I see the vocal cords. There's the glottis, the opening. I'm going to say, can you hand me the endotracheal tube? Now this person on this side, when they hand the endotracheal tube, you'd pull the package off of it. You've already tested the cuff, stylet's in, everything is good to go here. You're going to hand it to this person about like this. So they're going to reach up, you're going to hand it to them like this. Don't hand it to them like this. Don't hand it to them like this. You're going to hand it to them like they're going to insert it. That's the best way to be the best assistant you can. So I'm going to ask for the endotracheal tube. So I'll find it. I'll say suction. Maybe I'll say suction. Then I'll say, hand me the endotracheal tube. I'll look like this. I'll find the glottis. And I'll be like, oh, well, I'm having trouble finding it now. Okay, there we go. I found it. I'm going to insert while I'm inserting, so while I'm trying to insert this into the trachea, this person over here that's assisting is going to be taking the bag valve mask, and they're going to remove this. So you're going to remove this off of here, set this down. Don't be like, throw it across the room, drop it under the table, under the bed or something. You're going to remove this because you are expecting this tube to be in, and you're going to need to give a ventilation through it so somebody can listen to breath sounds. So as that tube's going in, and you can kind of tell by the body language of the person intubating that this might be going in, you pull this off. Now you're waiting now for, this should be the next thing in your hand, you're waiting for the person to be able to attach this. So I have it, I've inserted it into tracheal tube. This person that's intubating will close that off. A lot of times we'll secure this. Sometimes I'll hold this, sometimes the person that's assisting may grab this and pull it out. I like to pull it out myself because I know that I have a tight grip, because if you just pull everything at once, it'll pull it right out. So I'm gripping the endotracheal tube. This comes out, and then guess what? You are already prepared because you had the mask off. This goes on the end of the endotracheal tube, and we're able to give her breath. Now, this is a beautiful case because we don't have to use a stethoscope because we can see the lungs expand, but our patients are not usually in this condition where both lungs are exposed. So we're going to give a couple breaths. You're going to listen to that. You're going to see change of end-tidal CO2. That's another piece that actually comes with the bag valve mask, end-tidal CO2. And then now we're at the point where we can ventilate the patient. The issue is it's inserted. Sometimes the assistant will push this air in and pop this off so that now the cuff's inflated. So bag valve mask attached, inserted, blown up the cuff, everything is running. This is a two-person game right at this point. So one person over here is ventilating, this person is securing. And then usually what will happen is you'll give this either to the person intubating, and then you go to the third thing on the list, which is the securing device. So now you'll need to secure it. And that's why we had those in that order, those 5 different pieces in that order, because we're going to go to the securing device, and then either the assistant, and if they haven't done it before, that's absolutely okay. The assistant might have to hold the endotracheal tube and ventilate, while the person intubating then secures the endotracheal tube. After that's all finished, then you can let your hands off once it's secured, and you can ventilate through this, and you don't have to have that extra hand holding that tube in place because you have the securing device holding it there. From that point, you put them on a ventilator. And then you're good to go. So let me go back through that real quick just to show it one more time. Okay, 5 items we have as a review. Laryngoscope blade and handle, light works. Suction and a rigid tip or Yankauer, full suction turned on. Bag valve mask, with the mask attached, oxygen running at 100%. Endotracheal tube with the cuff that's already been tested for integrity. Usually, in my case, I like to leave the syringe attached and the semi-rigid stylet inside. The bottom half is packaged. And the last thing that we have is the securing device. So let's go to ventilate this patient. We're going to ventilate. Okay. Patient sedated. We're ready to go. This goes down. Laryngoscope blade and handle come out. We open it up. We take a look. Oh, what do you know? We need to suction. Waiting for suction right here. That's one of our 5 items. The suction is handed to the person intubating. They can look, clean it out. Great job. Next thing I want to ask for is the endotracheal tube. So from this side, they're going to hand endotracheal tube, take it out of the package. We're going to find the glottis again because I had to look away for intubation. And we're going to intubate this patient. And this one, okay, excellent. So we're in. At this point, I've secured. While I was doing that, you took the mask off of the bag valve mask, after the bag valve. So now we just got bag valve. Inflate this. Pull that off. We have a secured airway now, so when we deliver that breath, it's going to go directly in the lungs. This piece comes out. This attaches. And we give a breath and we can verify the endotracheal tube's in. At that point, we're going to continue ventilating until we go to secure the endotracheal tube with the commercial device. And those are the 5 pieces that you're going to need. What I would recommend, if you've never helped with this before, is that you stick a stylet inside of an endotracheal tube. You get the feel for inserting this air and pulling this off. That's really important. So putting air in and pulling it off, pulling that stylet out to get the feel for that. And then also, really important, know where this piece goes. I know, but in the rush, sometimes it's difficult. Sometimes it doesn't have this cover on the side. People will try to attach it there. It will not attach there. It will only attach here. While they're intubating, you're going to pull this off so that you're ready to be able to ventilate the patient. Now, I hope this was helpful today, going over 5 different things you need to have ready if you're assisting with intubation. Please reach out, like, subscribe. You're going to see my number of subscribers at the bottom, and I'm just asking you to subscribe. That's all I'm doing. It keeps me going, and I appreciate y'all watching. I hope this is useful in your practice. Reach out if you have any questions about other videos. I will see you the next time. Later.
Every ounce of anxiety bow itself at Jesus.